Hi everyone, I'm Clark with CK Med, and this episode is powered by Med School Tutors, your resource for one-on-one online tutoring for the USMLEs, shelf exam, and even the residency application process. Our tutoring incorporates custom study schedules, content mastery, and even test-taking strategies that you're not really going to get anywhere else. And I know this because I used to be a student with MST before I even tutored here. For a free phone consult, use the link in the description below. Mention that you heard about MST from CK Med on YouTube, and use this discount code CKMedPlus for your special pricing. I hope you enjoy the video.
Hello everyone, and welcome to CK Med. My name is Clark, and I'm going to take you through skin, bone, and muscle infections. This PowerPoint has been adapted from Nikki Shaw, so shout out to him. Let's go ahead and get started. So the first thing we're going to be discussing is our bacterial infections and how they incorporate themselves in causing us multiple skin problems in addition to the tissues that you find under. So let's go ahead and start off. So the first is going to be your Pasteurella multocida. This is found normal flora in your upper respiratory tract. However, it comes into play in skin abscesses following bites from cats and dogs. So this is something that if you have someone coming into your emergency department and they just got bit on the side of the road by a stray dog, you want to make sure you're giving them antibiotics to cover for this guy, especially because the possibility of abscess formation from them. So next in our dermal infections, we have our group A Streptococcus pyogenes. It is a gram-positive cocci. It's beta hemolytic and bacitracin sensitive. I'm sure you might have seen this on the sketchy videos. However, this one might be a new one, that it is optogen resistant. So usually optogen is an antibiotic to differentiate two entirely different streptococcal organisms, such as your strep pneumo from your virulence group. However, the when in doubt here, or the rule of thumb, is that if it's resistant or sensitive to one, then it's going to be the opposite on the other. So here we have bacitracin sensitive, so therefore it's optogen resistant. Or if we had an organism that was, as far as our streps go, if it was bacitracin resistant, then it would be optogen sensitive. And so that's how we kind of can remember that rule of thumb for these four organisms within your streptococcal species. Another one that's very specific to this and one other group is the rapid pyrrolidonyl arylamidase test. This guy is positive, so strep pyogenes or group A strep is positive for this PYR test. The only other organism group that is positive for this is your Enterococcus, which is also used to be called group D streptococcus. So the variants for this, it has an exotoxin. It has a whole bunch of different things that it can cause as far as symptoms. So we know it as pharyngitis, our common strep throat. And then following strep throat, we can get two complications, which is your rheumatic fever, which is type 2 hypersensitivity, and glomerulonephritis, which is type 3 hypersensitivity. Other diseases you'll see can be your scarlet fever. So this is not only something that has strep throat-like symptoms, but also has tongue problems and skin problems and everything like this. So this is where it kind of comes into play for skin. So scarlet fever is it has this sandpaper rash. It's also known as scarlatiniform. But remember, there's a couple other things that can cause a scarlatiniform rash. So that's that sandpaper rash, such as Staph, which is toxic shock syndrome toxin 1, and that guy can cause the scarlatiniform rash as well. Other presentation with scarlet fever, and this is one of a few things, is strawberry tongue. So another thing, if you're thinking and you have an infant that comes in or a child that comes in with a strawberry tongue, be thinking of scarlet fever as possible, but also you got to remember that there's a few other things that cause this, and Kawasaki's disease, which you will learn in PATH, or if you already have learned, can cause this as well. So that's a differential. Other things can have hemorrhages on the palate. You can find that in scarlet fever as well. And then the more common is Impetigo, Erysipelas, and cellulitis, and we'll get to those in just a little bit. So another organism is your Staphylococcus aureus. So this is gram-positive cocci. These are organized in clusters where your strep is going to be more in chains, long chains for pyogenes, short chains for Agalactiae. Staph aureus is beta hemolytic. It is catalase positive and coagulase positive. Remember that you have to know these two things to separate Staph aureus from the other staphylococci is that it is coagulase positive. Etiology can be found all over the place, but it can be found within granulocytes. Virulence for this, it has a coagulase, obviously. It has hemolysins, hyaluronidase, nuclease, lipase, protease, all those guys. It has alpha toxins, which can destroy RBCs. It has a protein A, and this is very specific. You actually should definitely know this is high yield. So it has this protein A variance factor, which is kind of a protein out on its surface of the organism. And what it does is there's antibodies that are floating around. And usually we want antibodies to bind via the FAB portion so that it exposes the FC portion for our phagocytes to recognize I have an antibody's FC region pointing towards me, and I have it stuck to an organism. Let me absorb and eat this entire thing, or phagocytize this whole thing. But it has to recognize the FC portion. So what protein A does, actually, for this organism, it binds that FC portion, so the FAB region, or the thing that should be binding to stuff, is actually exposed, floating out. And so what our phagocytes do, they come up and they say, oh, well, here's an FAB portion. I don't recognize this, so it passes right past Staph. And that is why this virulence factor is so severe. So it binds that FC portion of IgG, and that is for evasion of phagocytosis. The other thing that we're going to get to in just a second is the Pantone-Valentine leukocidin. This is very specific to community-acquired MRSA, and we'll be talking about that in just a second. Another thing that it has is penicillinase, so definitely you don't want to be prescribing your penicillin G to someone that has staph because they're almost across the board inherently resistant to penicillin G, and that's our Staph aureus. So diseases or symptoms that these guys can present with beyond just the general skin infection like abscesses or whatever can be your scalded skin syndrome toxin. So this is exfoliatin toxin. This is something you're going to find more often with children. What it does is it actually creates this toxin that goes in and it attacks in your stratum spinosum and stratum granulosum. It attacks desmoglein 1, which this protein is found in your desmosomes. I'm sure you remember from histo that's the thing that holds our cells together and allows kind of communication in between them. This protein that's holding them together gets destroyed, and so the cells start to separate and split off, and that's what leads to the skin kind of sloughing off, and that's why it's called exfoliatin toxin. Toxic shock syndrome toxin, TSST1, is an exotoxin, a superantigen. This is something you definitely need to know as well because it presents very similar to our scarlet fever because it can have strawberry tongue, it has scarletiniform, has that rash, right? Also can have vomiting, diarrhea, high fever, and then you'll have some of the desquamation sometimes with this. It usually progresses into shock. And remember what this does is our superantigen kind of binds our T cell receptor, which is attaching to our MHC molecules, and it kind of causes it to stimulate even though the T cell wasn't going to respond to whatever antigen was being presented. But now it is. And so therefore our T cells secrete out tons of cytokines, and that causes like a cytokine storm, which can lead to all these symptoms found here. Usually this is more associated with someone like a female that's on her menstrual cycle. She has tampons that she left in, and if staph is growing on there, it can secrete this toxin. Other things are patients that come in the emergency department with nosebleeds. If they have nosebleeds, they can have a little bit of packing stuff, like pretty much a tampon you shove in the back of their nose and fill it with saline to stop severe nosebleeds. If you leave that in for a little while and it's got staph growing on it, it can secrete this toxin leading to this syndrome. All right, so now a little bit more specific about MRSA. So this is our methicillin-resistant Staphylococcus aureus. We have two types, our community-acquired and our nosocomial. So the nosocomial I'm going to actually cover first. So it's usually often resistant to a lot of antibiotics, so it's a little bit worse or harder for us to treat, but it's less common, I guess, that we find. It's usually due to exposure in a hospital or recent hospital discharge in the last few days or something like that. It can cause pneumonia and all sorts of problems. Where on the other hand, our community-acquired is the one that secretes out some of our toxins, and this is something that we need to pay attention to as far as micro questions like to ask. So our community-acquired MRSA, so it's susceptible to clindamycin, which is an antibiotic, something that blocks translation process. It binds onto our ribosome, and stopping for our tRNAs dropping off our amino acids, and that's what clindamycin does. This community-acquired MRSA actually carries a PVL, which is that penton-valentine toxin, which is kind of what this little comic little guy is showing up here. This is also resistant to MRSA. Why? And so this is something that board questions like to ask, and UWorld I'm sure you'll come across at some point in time. But this is where it's not just a penicillinase. Remember that our staph secretes that penicillinase that breaks down our penicillin G. That's why they're inherently resistant. But why is this one very specific for methicillin? So what happens is we actually have penicillin binding proteins, which are the proteins in our transpeptidases that kind of build up our cell wall. And so these particular proteins or binding attachment sites is where our penicillins work. They stop this protein transpeptidation, and therefore we can't build our cell wall. And so our antibiotics would go there and inhibit that. However, what happens is if we do a little bit change or in that binding site, now our antibiotics won't bind there very well. And that's exactly how methicillin resistance comes upon in Staph aureus. And so this specific protein is, it's called penicillin binding protein 2A or PBP2A. And this is encoded by a cassette. And a cassette is similar to like a lac operon or something like that you can find in bacteria. But in humans, we actually have longer chains of these things, and these are known as cassettes. And the particular name cassette that codes this PBP2A is known as MEK-A. And so you're only wanting to look for a mutation in MEK-A or a change in genetic sequence in your MEK-A gene that leads to penicillin binding protein 2A change as far as that protein that's produced. And that's how you get that methicillin resistance in Staph aureus. All right, now on to a little bit more of infections. I know the bacterials are not very fun. It gets a little bit better when you get to the worms and stuff. But we'll try our best to get there as quickly as possible. So another infection is Impetigo. This is an epidermal infection, and usually it's always staph, right? But staph is so boring. So if they were just to say Impetigo and the question wasn't asking what are complications or something like that, or it didn't spread very well, or it's not really warm and hot, it's just, flaking and looks crusty like this little kid down here in the corner, then the most likely organism you want to choose, and if it's asking what is the most likely organism, you're going to want to say staph. However, this question would be really boring and defeat the entire purpose of wanting to test you on what could the other organism that could cause this, and obviously complications that come from this. So remember that group A strep also causes this, and this is one that leads to, yep, you guessed it right, glomerulonephritis. And so Impetigo can lead to, obviously, pharyngitis after that, and then rheumatic fever. But if it's just Impetigo, the skin infection usually is a little bit self-limiting. You can give antibiotics for it. But eventually 2 to 4 weeks, if we don't treat this patient, they have the possible complications of post-streptococcal glomerulonephritis, which is a type 3 hypersensitive we talked about. So presentation is small vesicles with erythema. They usually become pustular, and then they pop open and crust over. And we call this our honey-crusted or golden-crusted flaking lesions. And it looks just like this kid's presenting down here. So now a little bit more about our dermal. So we know that in our epidermis and our dermis, we have our hair follicles that progress all the way through them into the dermis and sometimes even in the hypodermis. And if we have an infection of our hair follicle, not including the glands that are supplying and squirting out, sebum and all that stuff into the hair follicle, just the hair follicle itself is known as folliculitis. The most common cause is going to be staph. If it's someone that has folliculitis after they've been in unchlorinated hot tubs, then definitely be thinking of Pseudomonas aeruginosa. That might be what that question's kind of getting at. If it's just acne, and they're referring to someone that just comes in with little pustular lesions, they're worried about their looks at school or something, they're just really talking about acne. And so at this point, they might be just asking you a simple question: what causes acne? And you should know that it's Propionibacterium acnes. And what this guy does, it feeds on sebum and keratin in the skin, and that's why it is a common cause of this acne. And so definitely be able to spot. Don't be tricked. They're not always asking you about crazy infections. They're asking about what is a common thing that you're going to see in your pediatric rotations or something like that. They want you to be able to recognize what a pimple is, right? And not assume that it's Pseudomonas aeruginosa because this person maybe was swimming in an unchlorinated hot tub. No, it's probably just acne on their face and they need to stop being babies, okay? You're like Pop It or something, right? So risk factors for folliculitis, however, is shaving. I know for you guys, I'm sure you recognize this after you do a nice clean, close shave that the next day or even that later day, you get a little bit agitated, a little red hair follicles that are a little bit inflamed, and that is just the basics of folliculitis. If it progresses to, pustular lesion, then that is more definition of that folliculitis. Diabetes, acne, obesity, all those things increase risk for this. Now, diabetes and those obesity risk factors for the last usually progress to something a little bit worse, and this could be something like a furuncle, which is a hair follicle plus the gland, and then if you put a bunch of furuncles together, it can lead to a carbuncle. So a carbuncle is just a bunch of furuncles put together. These are usually found on the back of the neck because people don't wash the back of their necks very well because they can't see the back of their neck. Also, patients that have diabetes, this is something that is a risk factor. So definitely looking, if you have someone with something on the back of their neck and they have diabetes, they're wanting to look for you to pick something about carbuncle, right? And the most common cause is Staph aureus, and we have to assume that if someone comes in with an infection that I'm thinking it's Staph aureus, we have to assume it's MRSA. And so we have to cover them with antibiotics pretending it's MRSA, even if it's not. We have to cover them in case it's MRSA, okay? Because that could progress to something a lot worse. And the same risk factors as before. So now a little bit more about deeper tissues. So something that you're going to be coming across and definitely going to be high yield for getting a question on your exam, but it's very, very easy to differentiate these two, is cellulitis and Erysipelas. So to differentiate the two, I've kind of organized it in a little chart, nice and separated so you know which one goes to what. Okay, so the location isn't very important. Just know that it's under epidermis. So dermis portion is where it's infected. They're not really going to ask you the histo of where this infection occurs. They're more like, what is the organism? Why? You're in microbiology. You're taking a microbiology exam. The most likely you're not going to be getting questions about where is this infection particularly located. No, of course not. Unless it was talking about osteomyelitis, which we'll talk about at the very end of this. So the etiology for cellulitis is beta hemolytic strep. This is the most common, and it is also for Erysipelas. So you need to know more about its description in order to diagnose this. So for cellulitis, it is ill-defined borders. If you just remember ill-defined borders, or they're saying we can't tell where the borders is, or it's all like, spread out, it's diffuse, we can't really tell anything like that, then you're talking about cellulitis. Just done. Like that's all you really need to know right now. However, other things can help you, that there's track marks of lymphangitis and scant exudate. It's a little bit moist, like sticky and stuff like that. That's your cellulitis. Where Erysipelas is dry, it's raised, it's almost like plaques, but they have well-defined borders. And that's going to be your Erysipelas. But remember, beta hemolytic strep for both of these guys. Not Staph. This is not something, Staph does like abscess-like stuff. This guy kind of spreads and spreads out, and that's going to be your strep. Okay, so here we are with erysipeloid. This is caused from Erysipelothryx russophathia. It's gram-positive, catalase negative. It is pleomorphic and encapsulated bacilli. This is something you're going to be getting with exposures from people that work with swine or fish. They're butchers, veterinarians. They work on farms, something with animals. And what happens is they get a little bit of cut. Maybe they're a butcher and they're cutting up some animals or something like that. And they have this cut in their hand, and usually it occurs on their hand, and it's very, very, very painful, like super sore. You can't even touch it. They're like screaming at you. And it's slowly spreading. And then it has a violetaceous or violet or purple color to it. And you can see that up here in the top right. And that's going to be something that's very definitive of erysipeloid. And so treatment for this is going to be penicillin and erythromycin, which is a macrolide, and then specialties. So this is something that is very resistant to vancomycin. So you need to know which ones are resistant to what if they come up, because that's actually pretty high yield to know, especially when you're coming up to fifth term in farm. That's something you should definitely know as well. So vancomycin, these guys are resistant to. So if we pause right here and you think, what was the one that was resistant to penicillin G? That is correct. It is Staph aureus. So definitely remember those guys for those. If you can remember back to respiratory, which one was resistant to carbapenems? Anybody can think of that? All right. Hopefully you were thinking Klebsiella. That's the guy that's resistant to that. All right. So now on to some anaerobic infections. So these aren't super high yield as far as the skin goes, except for a few of them. We'll be discussing those. So usually they are infections of like the stool or lower GI, right? And so things such as your Bacteroides fragilis and stuff like that. But other things as far as the skin, you can be thinking of abscesses like pilonidal ones. So these are the ones that are in the crack of the butt or the top of the butt crack. Someone's been sitting for a long time, they're students or something like that, or they're just, overweight guy that plays video games and, sits in a diaper for 24 hours so he doesn't have to get up to use the restroom. That's someone that most likely is going to have a pilonidal abscess, and it smells really, really bad, like dying flesh if we cut that open. And that is because it's full of anaerobes. And I am very glad I'm not doing dermatology, so I won't have to experience that, or hopefully not in my rotations. But pathogenesis are obviously your gram-negative rods are the most common ones that are anaerobic. So examples like Bacteroides fragilis, it's very common, usually in your lower GI, and remember that can be associated with fistulas. Also respiratory infections like aspiration and stuff like that. Aspiration pneumonia is very common, associated with gram-negative or your anaerobes. Other things like actinomyces, right? We'll get to that in a minute. And then propionibacterium, like we were just talking about. And then lastly, Clostridium. We talked about bacillus, which is a spore former, and that is aerobe. And this is Clostridium, which is a anaerobe spore former. So this one is usually associated with like myonecrosis. It's usually associated with like dog bites, possible gunshot wounds, motorcycle accidents. Someone was in the desert and they got stabbed by sand people or something like that in Star Wars. You can think of all the craziest stories, but that's something that's going to be associated with Clostridium. If you're looking for myonecrosis, you got that like dark, bloody bubbles with bullae, right? So you got bloody bullae, and you'll have crepitations of those guys, and that's going to be your anaerobes. So Actinomyces israelii, this is a filamentous branching gram-positive rod. It's non-acid fast, and it is an anaerobe like we were just discussing. So usually what happens is we get this little abscess on our face, and this is following dental procedures or tooth extraction, or it's a homeless person with poor dental hygiene. Those sorts of things give you an increased risk of having Actinomyces israelii. So what happens is you form this abscess and pus, and it has these sulfur-like granules within them. You can pop them and pull them out. They're kind of like granular and dry. And up in the top right here, we actually have kind of a histology of what that granule looks like. So complications depends on where it is. It's not always in the face. It can be in like uterus, and that's from IUDs, aspiration pneumonia, and then the neck ones, which I had just discussed. All right, so here we have Clostridium perfringens. We just talked about this a little bit, so I didn't need to explain the organism. But the virulence for this guy, it's encapsulated and it can generate hydrogen sulfide gas and CO2, which makes that kind of crepitations, the soda pop bubbles under the skin. It also has an alpha toxin, which can diffuse, and that's the thing that actually causes more of the tissue damage necrosis, not just the bubbles. The theta toxin that it produces can damage your heart muscle and capillaries. It's similar to streptolysin O within strep. And then other things like our enterotoxin, which is something for our food poisoning we discussed in our GI section. So the fermentation of muscle carbohydrates is what leads to that gas production here. And that's going to be leading to that presentation we found. It also has a few other virulence factors that are more low yield for this, but it's good to know if you want to just read that. So diagnosis, because it's so severe, we have to just pretty much rely on our clinical diagnosis, and we can't just wait for our labs. But for our confirmatory tests, these guys are sort of high yield. You definitely need to know that this is something we grow on egg yolk agar. We add in vitamin K and hemin. Remember, this is your hema-10 or factor 10. And this is something to test that we can test for both lecithinase, which is only found within our pathogenic strains of our Clostridium perfringens, and our lipase. So whenever it has both of these, whenever it has lecithinase, then that's our virulent strain, but we want to be looking for it to have lipase negative. And so what happens if we have a lipase positive colony, it actually would be kind of shiny because it would be kind of incorporating the lipids on itself. However, these guys are not, and so they're going to be kind of pale, and they won't be putting the lipid on top of themselves, and that means they're negative for lipase. Another test that we can do is the Nagler test. This is also checking for lecithinase, and it's just testing for the toxin itself. So we take antitoxin and we throw in the organism, and if it produces the toxin, the antitoxin and toxin complex forms a precipitate that we can actually see on the plate, and so that's our Nagler test. The other guy is reverse Camp test. This is something that we kind of streak in a 90-degree angle to our group B strep or S. agalactiae or strep agalactiae. And what happens is hemolysis kind of goes synergistically, and it makes this kind of arrowhead appearance. I can't really draw arrowhead, but just imagine that's what the arrow looks like, and that's with our group B strep. So treatment for these, we kind of have to do surgical aspect of this. We can also put them in a hyperbaric oxygen chamber that can also help treat these patients. So next guy is erythrasma. This is pretty much you need to only recognize the organism name, the basic shape of it, and then what we find as far as Wood's lamp. So this is Corynebacterium minutissimum. So remember, this is related to our other Corynebacterium, which is diphtheria, which causes pharyngitis in that pseudomembrane. There's a gram-positive club-shaped rod, so it's got the same shape as our diphtheria. And then as far as Wood's lamp, what it does is it infects our skin in like wet, moist areas, feet, groin, armpits, those sorts of thing, and even on the back of the neck if you have long hair. And so this actually grows kind of coral red or bright red, similar to this picture you can see right here. And this is something that's really cool to actually see. I got to see this in India. And this is due to it having a porphyrin ring structure that kind of sends back that light in the Wood's lamp, which is your UV light. So neck fash. So this is something I'm going to tell you a little bit of story about this. So necrotizing fasciitis, infection of the skin and fascia that spreads very rapidly and is very, very painful. The person will be screaming when they come in. You think they might have broken a bone, but nope. Their skin is eating or is being eaten by bacteria. It's flesh-eating bacteria. So you're going to see very erythematous skin, and you can actually watch it move, which is terrible how quickly this moves. Warmth, tenderness, fever can cause a blue-gray color because it's pretty much necrotizing everything. Obviously, it makes sense. Boule, crepitants. You have to take them to surgery right away. Like immediately, you see that come in, you take that suspicion, you get them to surgery right away because that's what you're thinking this is. It can be caused by like multiple microorganisms, like in diabetics and IV drug users, but it can be monoclonal. Monomicrobial. This is usually caused from strep pyogenes. It can be caused from Clostridium perfringens after like a traumatic accident, like in the dirt or something like that, or they got in a motorcycle accident. But strep pyogenes is the guy you're really thinking for neck fash. So this lady actually over here, she was on Oprah in 2005 or something like that. I was a kid, and my mom was watching it on TV, and I walked in, and this lady was talking about how she was cutting some celery, and she cut her finger with her knife and started bleeding a little bit. She washed it off, but then it started getting really, really painful, and she didn't know why. And suddenly the tip of her finger turned gray-black, and it started dying right in front of her face, and she started feeling the pain more and more up the back side of her hand. And so she decided to go to the emergency department. By the time she made it to the emergency department down the street, literally she could have ran there and been there in about 45 seconds to a minute. Down the street, she drove down to the emergency department, and it was pretty much all the way up to past her wrist, about 3 inches past her wrist. At this point, it had already eaten away her entire hand. And so they had to take her up to immediate surgery, and they told her, okay, we're going to put you under right away, right now. Do you have any allergies? They needed to check that history. She said no. I'd been anesthetized before. And they said, okay, we're going to have to remove your arm. And so she gave them permission. By the time they put her under and prepared the surgery and cleaned her skin and everything, then remove her arm, it was at her shoulder. It was at her shoulder, and so they had to remove her entire shoulder and her arm and part of her breast, actually, because it started eating across that as they were removing the tissue. And so this is how severe this can be, and this is something that we need to take very seriously if we see that coming in the emergency department, not just thinking, oh, it's probably cellulitis or Erysipelas. Be listing your patient. They need to be taking into consideration their communication, their pain scale, and how rapidly the infection has been spreading. So another guy that is actually on the other side scale for pain is anthrax. So this is caused from Bacillus anthracis. So we know this is an aerobe because it's related to Bacillus cereus. It's gram-positive and spore forming. The etiology, you're going to usually have this relevant to herders and butchers, cattle, sheep workers, people that work with sheep and cattle. They live out in rural areas or something like that. So what this guy does is it multiplies in macrophages, and it forms spores and produces an exotoxin. Virulence it has a polypeptide capsule, and this is one weird thing about this. It's all amino acids. It's not just like peptides with sugars and stuff like that. It's actually just all amino acids. So this is something that's kind of weird about this one. It can form an edema toxin, which this causes adenylate cyclase, which increases pretty much secretion of fluids, which obviously leads to edema. And then a lethal toxin, which causes cytokine storm and inflammatory response, so then it can infect more of the macrophages and infect more of the area in the tissue. So there's three ways you can actually kind of get this, and so it kind of goes down in severity. So respiratory is the most. It's usually 100%, 99 to 100% lethal, so that's really bad. If it's ingested, it's about 50% lethal. And then if it's cutaneous, about 20% lethal. So these are actually really important, and they actually like asking questions about, do you know which one is worse than the other? So skin infections. So what happens is you have this initial hemorrhagic vesicle. It's all bubbly, and eventually it gets hard and it's painless. This person has a painless ulcerative lesion. So it's hemorrhage vesicle, it's hard, it's painless, then it erodes and pops open, similar to this guy. You have a bunch of necrotic tissues, usually black or blue inside. It can become very leathery and dry and necrotic. And this is what we call an eschar. So an eschar is actually a dark, ulcerated, indented lesion with necrotic tissue. And so that is actually the description of eschar. When you hear the word eschar or read it in a STEM, we're talking about anthrax. Done. Like literally just gives you free points. If you see eschar, we're anthrax. But not always where they mention that. They'll be more talking about the lesion itself, so you can recognize that is an eschar, and then you have anthrax. And so it's pretty much a scab with an indent in the middle. It's very dangerous. I wouldn't suggest searching pictures on Google because they can get very brutal, especially when they're infecting the face. All right, so now on to some of our Microbacteriums. So these guys can get a little bit annoying and boring. I'm sure you've heard them a lot. But as far as our cutaneous infections, so Mycobacterium tuberculosis actually causes two forms. So lupus vulgaris. Pretty much this means the common wolf. And so that's why they call it this, because it gives this kind of wolf-like appearance, like pushes out the lower portion of the face. And can cause edema, and that's what actually causes the wolf, and granulomas. That leads to that snout. Another guy is your tuberculosis verrucosa, and this is known as your tubercular wart. And it forms like a plaque or wart-like cutaneous lesion. Super rare, often on the feet, just like it's like a big wart. And they would say they would have acid-fast bacilli and to be tuberculosis. Okay, that's not too difficult. The next guy is Mycobacterium leprae. So this is called Hansen's disease or leprosy. There's two types of this. I'm sure you've heard never ending, but I'm going to repeat it here. This is Paucibacillary. This is tuberculoid type. This is the one that has your granulomas-like formation because it's a Th1 response or majority Th1 response. So our Th1 cells secrete out cytokines that tell macrophages form granulomas, and granulomas tell back the T cells, hey, can you keep secreting and telling me to make more granulomas? And so there's just back and forth communication in order to keep the granuloma formed. This causes hyperpigmentation of the skin, the macula. Peripheral numbness is something you're going to find here, and it's less deforming, but you can lose some limbs with this guy. The other one is multibacillar. This is lepromatous. This is mainly a Th2 response, which is an inappropriate response to something that lives intracellularly, and something we want to have our cell or CD8 T cells to be responding to. However, this is more stimulating a non-CD8 T cells, more of our antibodies produce, and that's not really doing anything. And so at this point, we just leave it up for the infection to cause very erythematous macula, papules, large nodules, which can cause severe disfigurement, similar to what this guy has here on his face, and pretty much most likely his whole body. So other Mycobacterium infections, so these are going to be separated from your slow growers to your fast growers. And so I put in this little GIF over here just to emphasize that these guys are slow because it's in slow motion. Okay, so we have 4 of them that are slow growers, and these are your Mycobacterium avium, Kansii, marinum, and ulcerans. So I'll kind of describe what they're really getting at when they're writing questions for these guys. So obviously slow growers, that's important. That's something they might mention in the STEM, or the laboratory kind of brought back your results. But Mycobacterium avium, this is more associated with HIV patients. You usually don't see this infection unless the CD4 count is less than 50. This is our last result infection that we're going to see with this, and it's usually, it's very similar to tuberculosis in the lungs, but remember this patient is TB negative. They might have acid-fast bacillus, but it is TB negative, causing infection in the lungs that we're thinking it sounds very similar to Mycobacterium, but this HIV positive patient. Remember, tuberculosis also comes to rise in HIV positive. It's actually the most common killer of patients with HIV, but this guy is TB negative. So that's something definitely you should know to differentiate. Other guys, Mycobacterium kansii. This is chronic lung infection. IC patients, it's similar to TB as well, but this one grows on agar with a photochromogen yellow-orange pigment, which you can see actually these guys growing here. And so it's something they can't really differentiate Mycobacterium kansii and Mycobacterium marinum if it is involving the lungs. But that is kind of the basis that says this is kansii. If it's yellow in the lungs, then it's kansii, just think that. If it's marinum, more of granulomas like on the skin or the hands or something like that, someone was, they're marine biologists, they're swimming, they're working with fish, they get cuts, something like that, and it grows photochromogen yellow on the agar, then you're thinking that this is Mycobacterium marinum. So that's this is actually more high yield. I know there was on that slide that said the photochromogen yellow and all that stuff, it said FYI in the corner, you actually do need to know this. This was on a test question that we had, so definitely know your pigments for them and how to differentiate all your Mycobacteriums. It's not too difficult. Hopefully this is a nice organization. So Mycobacterium ulcerans, so it's a painless nodule, very similar to our anthrax that we were just discussing. It doesn't form an eschar, however, it's just a big nodule. It's itchy and then can ulcerate actually pretty deep, but not a lot of your dead necrotic tissue. We don't describe it as an eschar. And this person really is not getting this infection from working with animals. It's usually just from other infected people. Another two organisms are your fast growers. So this is our little guy from Go Dogs Go. If you've seen that video when you were like, 4. So Mycobacterium chelonae, this is one of our first fast growers. So lung, joint, eye, organs, infections, but it's very fast growing. So this is something you're going to see in CF patients. Mycobacterium fortuitatum, it's ulcerative skin lesions, bone, joint, eye infections. So you're like, oh man, how do I differentiate them? Well, pretty much they write you a question of someone has something, they have acid-fast bacilli, they're negative on TB, and they're fast growing. And then guess what? Out of all your options, you're going to see one or the other. They're not going to put both and try to have you differentiate. You can't. There's not enough information you were provided to separate them. Pretty much you just need to know one or the other is going to show up as an answer choice for these guys. These are your fast fast growers. All right, now on to our rickettsial infections. So now we're getting a little bit more interesting. So Rickettsia are small, well, you can't really gram stand them, organisms that live intracellular. They usually infect our endothelial cells. As far as the two organisms you should know, Rickettsia rickettsii. This is transmitted, and this is pretty much the cause of Rocky Mountain spotted fever, and you're going to be getting that transmitted from Rocky Mountain wood tick, American dog tick, and brown dog tick. You'll be learning this more about these guys in your multi-system module, but as far as I just want to introduce you guys that there's a lot of ticks for even a single organism, so you should definitely be aware that that's going to be coming up in your future. These can be found in the goat states, so Georgia, Oklahoma, Arkansas, and Tennessee. But not within goat is actually where you have your highest prevalence, which is in North Carolina. That's the most prevalent location for this. Rickettsia prowazekii is transmitted from lice, like they defecate through human wounds, which is fantastic. I just would love to have a wound and have lice just defecate in it. That would be fantastic. I just want this guy really bad. It's disgusting. And so this is your typhus. And so definitely be able to differentiate those guys. So Rocky Mountain spotted fever, pretty much it's a centripetal petechial rash, and we'll be talking about what those rashes mean, but I want to introduce it now. So centripetal, that's why I have that T, is centripetal rashes start out in the extremities and go to the trunk. So centripetal petechial rash. Something that when you push on the rash, it goes away and then it comes back right when you open it. Why? Is because when these guys are infecting your endothelial, it actually causes bleeding into those little areas, and that's why you have petechia. So it starts in the wrist. So this is how I remember this is Rickettsia starts in the wrist. Rickettsia starts in the wrist. Rickettsia starts in the wrist and goes to the trunk because it's centripetal. Then it comes back to your palms and soles. This is one of a very, very few infections that involve your palms and soles, and this is one of them. So you see palms and soles, you're thinking only a few, and we'll be coming across a few of those. The other guy is louse-borne typhus fever, which we talked about. That's Rickettsia prowazekii. And so typhus actually starts in the trunk. So Rickettsia starts in the wrist. Typhus starts in the trunk. And this is something, when it starts in the trunk and moves towards your fingers, it's centrifugal. It goes towards your fingers, it's centrifugal. If it goes towards the trunk, it's centripetal. Okay, that's something you definitely need learning and knowing. This guy can cause gangrene and all sorts of problems. So PCRs are best for diagnosing these guys because we can't really scrape our endothelial cells to get them out. That would be problematic. And remember that since they're intracellular, we're going to have lymphocytes responding to them. And that's why you actually bleed. Another thing that we used to do is the Wheel Felix test, and pretty much we take our Proteus, which is the bacteria that causes UTIs, urinary tract infections. We take its antigens, put it on beads, and then our antibodies that this person makes against Rickettsia actually can agglutinate those beads with that Proteus antigen. And that's known as your Wheel Felix test. All right, and now a little bit of our spectacular syphilis. So this organism is a spirochete. It's known as Treponema pallidum. And we, as we know that our spirochetes actually don't have flagella that hang off of them. They actually have a flagella built into their cell wall, and this is known as an endoflagellum. So it allows them to kind of spiral and kind of carve into their tissue that they're infecting. So there's two actually stages that involve skin, since we're talking about it. So primary syphilis, this is going to cause a chancre lesion. That is not canker. Canker is what's in the mouth, usually like ulcers. These are actually chancre lesions, and it usually occurs in the genital area. And it's a circular ulcer with exudate that is hard on the outer rim. So this is actually a hard ulcer, and that's what's known as a chancre. The key feature about this is that it's painless. There is another thing that has a chancroid-like lesion, so you can kind of get them confused, but it's very painful, and that is actually an Haemophilus ducreyi, because you do cry. But that'll come up when you do your STDs in a later module. The second involvement of the skin is once that chancre lesion goes away, now this syphilis is allowed to kind of spread everywhere else. And as it spreads, it actually mimics a lot of different rashes. It's called the great imitator, so it could look like a maculopapular rash, it could look like papular, it could look like bullae, or it could look like this one down in the bottom right-hand corner, and this is actually something that you don't see with really anything else. So this is one of the defining types of rashes, but again, it can make it look like other rashes. So you want to be looking for they're sexually active, or they're homeless and doing lots of bad stuff. Any way that they can get this sexually transmitted disease known as syphilis gives more increased risk that the rash that they might be presenting with is something having to do with syphilis. But this guy down in the bottom right-hand corner is actually, it's known as your copper lesion. It looks like little pennies all over you. And this can also occur on the palms and soles. So we only saw a few things, or there are only a few things that involve the palms and soles. And one of them is syphilis, and one is Rocky Mountain spotted fever. In pathology, you might learn about DIC that can cause actually like petechia and purpura on your palms. But as far as infectious thing, there's only a few, and it's Coxsackie A. It spells out cars, right? So Coxsackie A, and then Rocky Mountain spotted fever, and then syphilis, CARS. The other progression that this can lead to is an accumulation, sort of like this wart thing. It's kind of gross in the genital region, and this is known as condyloma lata, where if it's a warty lesion due to papillomavirus, that is condyloma acuminata. That is strains 6 and 11. But this for syphilis is condyloma lata. So be looking out for warty lesion following syphilis, and that is condyloma lata. All right, another spirochete that you might have heard about is Lyme disease. This is also another spirochete, and it has endoflagellum. This is known as Borrelia burgdorferi. It is carried by the Ixodes tick, which is also known as the deer tick or the black-legged tick. And most importantly, you actually get bit, and transmission of this disease is occurring when the tick is in the nymph stage, which is like this little speck, like that big, or even smaller. If you can see this little speck up here. That's how big this actually ends up getting. It's very tiny. It is a gram-negative spirochete, and it enters the skin through the nymph bite. And this nymph actually has to stay there for almost 48 hours, 36 to 48 hours, in order to actually transmit this into there. It comes through the nymph's saliva into the skin and then causes infection. So symptoms, the first stage of this is actually the erythema chronicum migrans, or erythema migrans. That's your bullseye rash, which I actually have depicted down here in this bottom right. And pretty much what it starts off is a small ring just like this. Pretend there's no ring out here. It's just this small portion like this, and then it starts spreading, and a zone of clearing appears in the middle. And then that's how you get this ring like this, with a zone of clearing in the middle here, and then another erythematous area. And so that is known as erythema chronicum migrans. If you were to chop out part of this skin right here to test for this organism, you actually would find it. And so these guys kind of like spiral outwards in this direction. And that's how they kind of make this ring. And it makes sense to the name. The second stage, this rash goes away, and you're going to have fever and CNS. This is something that just simple like fever and like photosensitivity and stuff like that. Maybe not to this severe extent of meningitis that this guy can cause, but symptoms such as facial palsy, even cardiac involvement. So this can infect the myocardium and cause problems with your heart. And then we also have the later stage, which is a little bit worse, and it's joint pains that last for a long amount of time, even after treatment. Sometimes if these patients present with joint pains and we give them antibiotics, it might clear them of the organism, but they still have lingering joint pain for years and years and years. So this is something we need to treat right off the bat, so they don't have to go through these, and then they'll actually keep coming back to you as a doctor. So definitely help them out with it. Other thing is the stage 3 is where we can have actual meningitis caused from this guy. When you get to the CNS lectures, you're going to be learning about the different ways that organisms enter into the CNS, like how does it cross the blood-brain barrier. And so since they're spirochetes, I just always think of it this way. You have a cell, and some of the organisms actually come out here, they get endocytosed, they pop the endosome and then they enter. And this is an example of like tuberculosis. That's exactly what it does. However, spirochetes, because they're spirally and like corkscrews, they actually go kind of corkscrew their way in between each of the cells in order to cross the blood-brain barrier. And so that's exactly how Lyme disease causes meningitis. Diagnosis for this is enzyme immunoassay or ELISA. You check for the antibodies in their serum. You can also confirm with a Western blot as well. But ELISA is the big guy for that to see if you have antibodies for it. All right, so now these two organisms that they were my bane of existence until I studied them a little bit more, and it's actually quite simple of how they ask questions about them. So this is Ehrlichiosis and Anaplasmosis. So I set this up in a column kind of trying to organize this information so it's easy to spot a question on what. If it's on Ehrlichia or is it on Anaplasmosis, and kind of how it presents. They often present very similar, and they often present in the same region in the United States, which is the northeast, the east of the United States. So they have a crossover. So anaplasmosis is carried by the Ixodes tick, which is where Lyme disease is carried. And the Ixodes tick is usually found in the northeast United States. So that's one of the epidemiology regions for both of these guys. And I didn't want to write that down on the slide because I wanted to connect them there. And so it's northeast United States is where the highest prevalence of where our Ixodes tick is. So therefore, the diseases that the Ixodes tick is going to be carrying, such as anaplasmosis and babesiosis, as well as our Borrelia or Lyme disease. Those guys are all carried from there. I'm not covering babesia here. That's when you get to your multi-system section. That guy's a little bit interesting. It's kind of cool what they look like on microscopy, but I'll cover that then. So to differentiate these two, so Ehrlichia schoenfensis and Ewingi. So Ehrlichia, they're gram-negative intracellular, causes fever, malaise, headache, myalgia, confusion. However, this guy is more specific that it has conjunctivitis as opposed to anaplasmosis. So be looking for something that has fever, malaise, they had a tick exposure, and then they have conjunctivitis. That might give you an extra hint, but don't choose it based on that, because anaplasmosis can have conjunctivitis in very rare cases. So don't choose it on that. You want to get a little bit more information out of your stem. And so often Ehrlichia also has a rash, although it's rare overall for both of these guys. Since we're talking about skin, it's a little bit more important to talk about what skin anomalies can occur. And so for Ehrlichia, you actually can have a rash, like a little bit. It usually occurs in children, so be looking out for a kid that's playing outside in the north or in the east, and that might give it away a little bit. So this is carried by another tick. It's known as Amblyomma americanum. This is a lone star tick. It usually occurs from eastern Texas up until about North Carolina or Virginia, just kind of like a swoop of the whole South over to the southeast of the United States. And this is what's carrying Ehrlichia. So the thing is, to differentiate these two actually comes down to what we see on histology, and I'll be describing that in just a second. So let me talk about anaplasmosis disease. So Anaplasma phagocytophilum. So this guy is actually a gram-negative intracellular as well, so they're very similar. Fever, malaise, headache, chills. Chills you still can get in Ehrlichia. I just didn't write it there because it's less common. Confusion, but this guy usually doesn't have a rash. So again, that rash thing is kind of helpful. In addition to conjunctivitis is a little bit helpful. Remember, it's not an all or nothing once you see that conjunctivitis. This is carried again from the Ixodes, so that's your Western. That should be black-legged tick, and black-legged ticks, just not the Western ones. So how to differentiate these guys? Actually, I have this little mnemonic. It's in first aid. It's called MEGA, and they say mega berries, but that's actually wrong because the berries is actually for ME. But I just remember MEGA, and this is keeping it organized for me. And so they have these mulberry or morulae inclusions that are found within certain of our immune cells. And so to organize which one is for which, you just organize it in MEGA. And you can see that Ehrlichia is found in your monocytes. And so up here in this top left picture, you can see a nice monocyte. You have a smooth nucleus. It's a very large cell, and it's obviously absorbed and eaten something. And you can see this kind of berry-looking thing. It's got little red and purple, so it almost looks like a ripening berry. This is known as a mulberry-like inclusion, or a morule, and that's found within monocytes. That is more common. You're going to find this more common with Ehrlichia. Where on the other hand, if you have morule or morule inclusions or mulberry inclusions in neutrophils or other granulocytes, then that's going to be something more with anaplasmosis. So here I have this large neutrophil. You have 1 lobe, 2 lobes, 3 lobes of this neutrophil. You have your granules found within the cytoplasm, and then I see this giant inclusion, and that is actually our morule. And since it's a PMN or a neutrophil, this is something that I'm going to say, if I have an inclusion in a neutrophil, this is more of our anaplasmosis. So the symptoms help you to bring it down to these two. Then you got to look for where is the inclusion to get you exactly which one this is. So that's Ehrlichia trophensis or wingy for monocytes, and anaplasmosis phagocytophilum within your granulocytes or neutrophils. All right, so now into a little bit more fun stuff. So this is cat scratch disease, meow. So this is caused from Bartonella hensleyi. It's also known as trench fever. It is a gram-negative rod. It's curved, aerobic, intracellular. You get it pretty much from cat bites or scratches or even the fleas from the cats. And usually it occurs in children. So this is something you're going to see maybe more common than not in practice, but also it's actually really easy to spot because it's always like a child that they write in the stem. So almost like a 5-6-year-old kid comes up to his mom and says, "Ow, ow, ow, my armpit hurts really bad." And you see a little scratch on their hand, and they just got a new cat done. Like, you don't even need anything more than that. But however, they do sometimes give you a little extra. So the disease presents with a regional lymphadenopathy. So if it's in the hand, you're looking for axillary lymph nodes swollen, right? If it's the back of the head, then you're looking for post-auricular lymph nodes or posterior cervical lymph nodes swelling. Remember, this is something we're going to come up in the viruses that I want you guys to recognize. That we actually had a question. It was very tricky. And they said that the patient had post-auricular lymphadenopathy. So this is something you actually find with rubella. It's one of the features of this viral infection. But differentiating features, this doesn't lead to a rash. So if you have posterior auricular lymphadenopathy, look for a scratch or look for cat scratch disease, as opposed to someone that has like rubella, which would present with a rash all over their entire body. And so that's one of the differentiating features. No rash, then you have cat scratch disease. Why? Because posterior auricular lymph nodes usually don't swell for anything. You have to have something particular that's causing them to swell, and that would pretty much have to be a scratch on the back of the head for this guy, or rubella, and nothing else really leads to those lymph nodes to swell unless you have an abscess on the top of your head. But they would probably mention that as the basis of your stem, right? They'd be talking about, oh, this guy has an abscess on the back of his head for staph or something. However, for this guy, this is what they usually like tricking students with. So I want you guys to recognize that. It causes these granulomas. They're called stellate granulomas. And they're kind of weird because they also could have some fluid within them. This is persistent infection. Sometimes can occur with patients that are, cancer patients or AIDS patients or something like that, and that can lead to overgrowth of erythrocytes because these cells infect a lot of tissue. They can cause erythrocytes and endothelial cells to overgrow, and this can cause a tumor-like formation. That's low on the high yield scale. Bacillary angiomatosis actually is pretty high yield. So this is something you need to differentiate between Kaposi sarcoma based on its etiology. So this is occurring in AIDS patients, which the latter is as well. But bacillary angiomatosis is going to be caused from your Bartonella hensleyi. So it's usually these small like tumor things, or like purple or black or red. They're pretty much just overgrowths of our endothelial cells, kind of making these miniature blood tumors on the skin. And that's something you need to be looking for as far as differentiating between the response. So because this is a bacteria, although it's intracellular, it still can be extracellular a little bit, and so you're going to be seeing PMNs kind of responding to this in monocytes. However, and also monocytes because it forms granulomas, where on the other end, if it's an AIDS patient and they have lymphocytes responding with these little tumors, then that's most likely HHV8 or Kaposi sarcoma. So diagnosis, you use, and I want to emphasize this very carefully, like I don't want you to miss this, okay? I know in lecture she said serology, but she meant serology for confirmation. The actual first thing you do, and you have to be very careful, is an indirect fluorescent antibody. Not direct, not direct. Indirect fluorescent antibody. They will put both, so I want you to pick the correct one. Indirect fluorescent antibody. That is something you want to be looking for cat scratch disease. Followed by serology to check for titers, and that will give you confirmation that this person has cat scratch disease. And again, remember, it's usually in children. All right, so now on to our viral infections. So viral infections are actually a little bit more fun, and then the worms and parasites are even more fun. So let's go ahead and get it down to our maculopapular rashes and the complications you get from that. So I want to describe kind of the basis of our maculopapular rashes. There's only a few, and they present in different progressions. How we organize them is based on how the rash kind of presents initially and how it migrates across the body. And so that's separated by your centripetal and centrifugal rashes. And this is really easy to remember if you just put it in the way that I have here. So centripetal is a rash that begins out on the periphery, so in the arms and the legs and the head. I want to emphasize this point. The head is a periphery. Here is your trunk. Here's your extremities, and these guys are all your extremities. The trunk is its own little thing. Your thorax and abdomen are separate from the entire rest of your body. So what this does is it starts in extremities and goes towards the trunk. Where centrifugal is something that starts in the trunk that goes towards the fingers. F for centrifugal. Okay, so it starts somewhere like in the trunk and then progresses outward towards your fingers. And I have a way to remember this in just a second. So go back to our centripetal rash. This is your smallpox, which is a true pox virus. And that's going to be something that has these pox or pustules that progress onto the skin, and they're all at the same stage. They're all vesicles. They're all papules. They are all ulcers or something like that. Okay, they are all at the same time. This is known as synchronous eruption, and that's why we give smallpox the designation of a true pox. Rubella is another infection we'll get to. These all cause maculopapular rash at one point in time. So rubella is something that causes maculopapular rash, and again, this is centripetal, so it starts in the head, usually more commonly in the forehead and the face, and progresses down into the trunk. Measles is another guy that starts in your forehead and progresses down your trunk and then spreads throughout the body. This is the progression for measles, and we'll be discussing those guys specifically. So for centrifugal, or the ones that go towards the fingers, I just think of, what do you hold in your fingers? Well, you hold chicken in your fingers while you're eating it, and you hold roses in your fingers. So why not assign those specifically? So when you're holding chicken to eat it, you have chicken pox. When you're holding roses in your fingers to give to, a beautiful girl or something like that, or ask them out to, prom or something like that. I know we're not in high school, but hey, you still can apply that in remembrance of those horrible days when you were in high school. So roseola is something that is a centrifugal rash as well. So chickenpox is caused from varicella, and roseola is HHV6 or 6th disease, and we'll get to those momentarily. So first is our measles. This is also known as rubeola. So rubeola. So this is our ruby, or our gem of the diseases, and something you're going to get a question on your test. So know it and get this free point. So this is a paramyxovirus, which means it is a single-stranded RNA negative virus, or group 5. It's enveloped. It's spread via respiratory droplets. The droplets actually are so small that they can actually stay airborne for several hours. So if a patient has measles that comes into your office, you need to make sure that all your patients find an alternate route or don't hang around in there for the next 3-4 hours, because that measles virus is floating around in the air. And if someone comes in 3 hours later, they can actually get measles. In addition, you can get it from fomites and stuff like that, so people touching the doorknobs and everything. So that's why you should carry hand sanitizer with you at all times, or just wash your hands very vigorously. So this is extremely contagious. This is one of the most contagious infections ever. And so there's actually this scale, especially for viral infections, that talk about your infectivity. So if one person gets infected, what is the average amount of people that you're going to infect with that single presentation? So if someone's sick for a week and a half or 2 weeks, how many people are you going to infect? And for measles, it's like 60 people that you can infect easily. Like, that is the average. So there's some people that get 80 or 100 or 200. And some people get, a couple or something if they stay at home. But the average is 60 people. Where if you take Ebola, on the other hand, that's something that only affects maybe 1 or 2 people. And that's your average. So you can have 0 as being very common. So usually it's due to malnutrition, overcrowding, and again, someone that does not have the MMR vaccine is not immune to measles, and so they're susceptible for this. So this is something we need to watch out for anti-vaxxers, and make sure we educate the parents and even some older children about getting vaccinated, and stop being big babies about needles. And make sure you get your vaccination so you can be immune to something that you won't end up giving a lot of people. Because complications come from this, this is something we want to treat. If it was common cold, then yeah, whatever. But this is something that actually leads to a lot of people dying. So we need to be careful with this as doctors. So what it does is replicates in the mucosa of the respiratory epithelium. It hops onto your CD46 and 150 lymphocytes and dendritic cells. Infects your epithelial cells around the body, and this is at the point where the rash kind of presents. So once it infects those cells, our CTLs come in and kill it, and that actually leads to the rash. So this virulence factors that it has hemagglutinin on it, and that's it. As far as its surface proteins, you need to know it has hemagglutinin, and that's it, okay? Inside of it, it has fusion proteins, which allow for syncytia formation, and the matrix protein is the thing that's holding the envelope to the nucleocapsid. For symptoms of this, it's prodromal, it's just a fever, it's sort of high fever, not very high, but this is a presentation that is common in a lot of things like upper respiratory tract infections, the cough, coryza, which is runny nose, and conjunctivitis, that's your 3 C's. Think of other ways that they can describe this. So spitting up from the respiratory tract is a weird way that they sometimes describe cough, which is so stupid. I don't understand why they need to do that. Coryza, so you could just say discharge from their nose or running nose rather than coryza. Obviously, they're probably not going to use the C for you. And then redness of the eyes. This is conjunctivitis, obviously. Just be thinking of stems, how they could write for this. They're not going to use these 3 C's. Why? Because that would be too much of a free point. However, diagnostic feature for this is your COMLEX spots, which I actually have up here in this picture. These are white, kind of bluish little spots that you find inside the mouth on the buccal mucosa. So if you can think of sensory from this area, that's your buccal nerve from trigeminal. And then the motor that comes out to this is your buccal branch, which comes off of your facial nerve. So that's a little bit a reminder of anatomy. Again, this rash starts in the forehead and moves down towards the trunk, and that is your centripetal maculopapular rash. It has confluence, so this is a feature that's only found in a few of our maculopapular rashes. And so what it means is that the rash, you have a little spot, maculopapular, and then you have another one next to it, and then it starts to grow, and they end up merging together and make this like merged glob of maculopapularness. And so that is actually your confluent or merging in this. You do not have that in rubella, so that's a nice differentiating feature for that. And they actually got a lot of people on that question for this. They made it present almost like it was rubella, but it was actually measles because the doctor didn't notice the COMLEX spots in the inside of the mouth. He didn't actually search for it. So be careful when it's talking about these rashes. So complications. Things obviously following viral infections, you can have secondary bacterial pneumonia, and you can also have subacute sclerosing panencephalitis. This is something complication you're going to get to in your nervous section, CNS section, but this is something you need to know. as a complication for right now. So clinical presentation plus the COMLEX spots, and then you can use, pharyngeal cell sample PCR titers and stuff like that. And then obviously our MMR vaccine covers measles, mumps, and rubella. So talk about rubella. This is also known as German measles. And this is actually a toga virus, single-stranded RNA plus, so that's our group 4, and it is enveloped. A transmission is transplacental very commonly, but also respiratory. So transplacental, this is in the first trimester when it crosses the placenta into the infant. And this can actually cause a congenital infection, which leads to opacity or cataracts of the eye. This is one of the most common causes of congenital blindness. Actually, it is the most common cause of congenital blindness. Cardiac defects, nerve deafness, like cranial nerve number 8. And this is actually sensory neural deafness. This is not anything like your bonus structures, anything. It causes hepatosplenomegaly, thrombocytopenia. When you have thrombocytopenia, it actually leads to what is known as the blueberry muffin syndrome, which is this guy right here. So, he's got these little blueberry muffins, and that is a congenital rubella. When I was in India, I actually got to see this little guy with these blueberry muffins, and so I wanted to show you. So symptoms for this, it usually occurs more often in adults. It has post-auricular lymphadenopathy. Remember I mentioned that when we're talking about our cat scratch disease or Bartonella. And this is low-grade fever, and then the actual macular papular rash, which is centripetal, so it goes towards the trunk. Similar to measles and smallpox. And this has also palatal petechia. This is a nice thing that you can look for to help you in the stem. Complications, arthralgias, arthritis, encephalitis, congenital. This could be a path tie-in when you get to endocrine if you haven't done it already, but this is something that hooks into diabetes mellitus. So if you have that slide for diabetes, definitely mention that rubella is actually a common viral etiology for diabetes. And also you can have thyroiditis, such as autoimmune thyroiditis and such like that. Diagnosis, PCR, it's a virus. You can also look for antibodies for that. That's common as well. And you need to do a titer comparison if it's congenital. Remember, MMR covers this, measles, mumps, and rubella. And this is your rubella or German measles. So parvovirus B19 is another infection. This is known as Fifth's disease or erythema infectiosum. You need to know erythema infectiosum. That's actually a very common thing that they put in stems as your answers. And so you need to know that you need to be choosing this if they present with the symptoms. So its transmission is respiratory droplet inhalations. Usually occurs in children, like schools and daycares, outbreaks like during the springtime. What it does is it replicates in the nucleus. Because this is actually single-stranded DNA, is group 2, and so DNA is going to go to your nucleus, and it usually occurs and goes to specific cells, and they're the precursors of erythrocytes, because erythrocytes don't have nucleus, so why is it going to go there? However, precursors to erythrocytes actually do have a nucleus, so it replicates there, so it goes to the bone marrow. It also can go to synovial fluid, so it can cause like dactylitis, swelling of the fingers and stuff like that you might see similar to sickle cell, but this is an infectious cause. And it causes, in the skin at least, this slap cheek face appearance, which this child is kind of showing down here. You see this big, very red cheeks, and that's known as your slap cheek rash on the face. It can also malaise, fever, the general viral infectious symptoms. Itching, lymphadenopathy, leukopenia, and anemia. So this is something we need to talk about. So complications are aplastic crisis. So this is patients that are at risk for this. We're going to be talking about in just a second with this mnemonic. But aplastic crisis, pretty much remember these guys are infecting your immature erythrocytes. So this is, if it's in the bone marrow, can actually cause quite an extensive damage to this and can lead to aplastic crisis. So this is something we need to be careful with people that are at risk with bone marrow problems or problems with bleeding and such. Other things is hydrocephalus if it's in congenital. So this is one of your torch infections. Sickle cell disease, thalassemias, that increases risk, PCR transfusion, and RBC. So I just put this mnemonic together. This is your 3 Bs. So babies are at risk, right? So your congenitals. Your blooders, so your blooders are the ones that have problems with blood, such as sickle cell and thalassemias, because this can actually induce that aplastic crisis, and that's something so high yield, not just for micro, but actually for path. Other things such as bearing babies, so pregnant women are also at risk for parvovirus B19. So we definitely want to keep, this is why we keep pregnant women around from away from dog poop. So if they just got a new puppy, hey, maybe make your husband clean up the poop for once, since he hasn't been doing that for forever. So make sure he does that. All right, next infection is your herpes virus 6 or HHV6. This is known as 6 disease because it is HHV6. Also known as roseola infantum or exanthum subitum. This is actually the more common name that we refer to 6 disease by. And so definitely remembering this. It's double-stranded DNA and enveloped, so it replicates in leukocytes, which can cause penias, similar to parvo that we were talking about, but except in white blood cells. It utilizes the CD46, which is an anti-complement CD molecule to infect salivary glands and epithelium. And the symptoms for this usually occurs in young children, usually less than 4 years of age. You have a very, very high fever. This is one of the defining features for this viral infection. So you have a maculopapular rash that begins in the trunk and spreads to the fingers because it is centrifugal. And it has a very high rash, a high fever, up to like 104, 105, 106. Then this is what we want to be very, very careful about because this is dangerous. It can cause brain damage with such high fevers. So we want to kind of lower their temperature. It usually lasts about 6 days, as to why we call it 6 disease, because it's a 6-day fever. It can lead to convulsions and leukopenia once it infects those leukocytes. This is something that we need to be watching out for. So this is a maculopapular rash that looks like roses, and it spares most of the face, so it actually is confluent, similar to our measles, but not like our rubella. Our rubella is not confluent, and this is a centrifugal, so this is one of the differentiating features. You see something that starts in the trunk, heads to the extremities. If it's not vesicular, then it's not chicken pox. Leaves you pretty much with her HHV6. You're done. Like you don't even need to. All you need is the rash, and you know what it is. Where if it's vesicular and all pustular and popping and stuff like that, that's going to be chicken pox. And we'll be talking about that in just a second. So other viral infections with rash, like West Nile. So this is usually something we get from mosquitoes during the summertime, or late summertime, fall time, when birds are actually up in North America. And in the central United States, and bringing the West Nile virus with them, and the mosquitoes bite them, and then they bite us and give us West Nile virus. Diagnosis, just IgM titers. Other things like dengue, Coxsackie, Epstein-Barr, scarlet fever, which is strep pyogenes, and adenovirus can cause infections. And I know scarlet fever is not viral, but these can cause other skin rash infections. So Coxsackie A6 is something that causes hand, foot, and mouth disease. It's like fever with sore throat at first, and then you'll have vesicle-like eruptions on the hands and the feet, and sometimes around the mouth. It also can present as macular or maculopapular in the mouth, fingers, and feet, sometimes in the buttocks. And that's going to be caused from your Coxsackie A16. Other disease that it can cause is herpangina, which is painful papular vesicular ulcerative ananthem, meaning exanthem means out on the skin, but ananthem means inside somewhere, so obviously inside the mouth. And this is something that if you see vesicles on the soft palate, not like papules or ulcers, but vesicles on the soft palate, you have herpangina. So you're looking for Coxsackie virus A16 causes both of these. Usually occurs in children. So HHV1, some of our other herpes viruses. HHV1 is also known as HSV1, so herpes simplex virus 1. This is something that causes a lot of people problems with like cold sores and such. This is something that is a latent virus, so it stays for a long time and forever. And if it is infecting the head or the face, then this is going to be relying and staying within your trigeminal ganglia. Remember that our herpes viruses like to stay and hide in our sensory nerve ganglia. For the face, we know that sensory is from your trigeminal nerve, so it's going to stay in that ganglia. So diseases that this causes is gingivostomatitis, which is usually in very small children, fever, sore throat, malaise, vesicular and ulcerative lesions on the mouth, like buccal mucosa and the lips, and it can also cause submandibular lymphadenopathy. Other thing is herpetic keratitis. This is ocular herpes. It's inflammation of the eye, gritty feeling of the eye, sharp pain, sensitive to light. That's not very common, so it's not very high yield. However, herpes labialis, this is actually very high yield. This is just simple terms, cold sores. A lot of people actually have this, and it usually erupts during stressful times and stuff like that. It's very painful, usually localized to the lips, pustular, and then it crusts, and then there's no scarring after. It just goes away. And the most common cause is from HHV1, but remember there is crossover between HHV2. They're both very similar viruses, but one infects usually the mouth, and that's one, and then the genitals is two. But remember there's crossover there, and I don't have to explain how that occurs. So viral encephalitis is another thing you're going to get to in your CNS module, and also can cause torch infections. So HHV2, this remains in your sacral ganglion. This is a cause of genital herpes. Usually occurs in utero transplacentally, which makes sense. Little babies coming through the genital area, and if the mother has this, then it can transmit it to the baby. It's usually during delivery is more common, and this is one of your H's for the 5 H's that you have that transmit viruses across during delivery, which is your HSV2, your HPV, your HIV, HBV, and HCV. All these occur and can be transmitted across to the child during delivery. This causes genital herpes, sometimes cold sores. Remember that crossover. A diagnosis is PCR and confirmed via the fluorescent antibodies. But what you want to do if you're doing histologies, you look for multinucleated giant cells with Cowdrey A intranuclear inclusions. It does that MMM, margination, multinucleated cells, and your molding, which is putting multiple cells, nuclei together. All right, now on to our pox lesions and not true pox lesions. So chicken pox is our not true pox. This is caused from varicella zoster, or HHV3. That is actually more high yield than actually the varicella zoster virus name. You should definitely know that it is HHV3. She didn't even really mention it in our lectures. I had to look it up, and she asked questions using HHV3. That was one of our choices, and that was the correct answer. So definitely recognize that this is HHV3. And so it causes a common cause of chickenpox, and you get it from respiratory droplets, but this is our primary infection. So remember that varicella is associated with our latent infection that can re-erupt as shingles. I'm sure you've heard of this since term 1 in anatomy, but if this is someone like a child that comes in with this infection, right, vesicular with crusts and all sorts of things occurring at the same different time, then this is something you want to be looking at. If it asks, how did this person get it? Respiratory droplets. However, if it's a re-eruption of this is known as endogenous reactivation. We'll be talking about that in just a second. So it enters through the upper respiratory, infects the mucosa, carried from phagocytes, and then replicates in local lymph nodes and spreads throughout the body, and that's why we have this rash all over in the skin, because it spreads all over the place. It's kind of randomly placed. It's not anything organized. And so what happens is this is caused a dewdrop on a rose petal appearance. I still don't see what a dewdrop on a rose petal appearance looks like, but this is a centrifugal. Remember our chicken, you're eating chicken with your fingers, so it starts in the trunk and moves towards your fingers, and that's a centrifugal rash. Causes abdominal pain, sore throat, headache, and the rash is actually, this is one of the defining features for this virus, is you'll have scabs, you'll have papules, macules, vesicles, all at the same time. So here, this is chickenpox. Someone has an ulcer here, a scab here, a blister here, and a papule here, and we took this picture, obviously, at the same exact time. And so this is something that a true pox does not have. A true pox, all of them will be blisters, or all of them will be ulcers, all of them will be scabbing, all of them will be papules at the same time. Where here, they're all in different stages. Like almost every lesion is in different stages. And that is a defining feature for chickenpox. So what happens is we leave this infection there and it goes away after we're children. Hopefully we had our live attenuated vaccine for it, which was presented in 1999. This is something we need to be looking out for in preventing someone having extreme stress or immunocompromised, because this can reinfect, causing shingles. And if they were to have someone that was presenting with shingles, again, I want to emphasize this thing in green, endogenous reactivation. They love getting people, the difference between respiratory infection, which was primary infection, and reactivation is endogenous reactivation. They love tricking people. People think, oh yeah, it's chickenpox, that's from respiratory, even though the patient's presenting with shingles. So read those questions very carefully. If it's asking someone with shingles and said, how did they originally get the infection? That means the first time they got it. Then yes, they're asking about respiratory, but usually they're asking if someone has shingles, how do they have it right now? And that is endogenous reactivation. Those are two different things of how this disease presents. So don't get those questions wrong. Definitely get them right. Get those free points. So complications, leukemias can come from this. It is actually a high risk of death with this in children, so definitely be watching out for that. Also pregnancy, so this is one of our torch infections. It actually is one of the most severe torch infections. It causes a lot of birth defects like cataracts, which we saw in rubella as well, petechia and purpura, microcephaly, and intracranial calcifications. Intracranial calcifications. Let me say that one more time. Intracranial calcifications. So this is calcifications actually in brain tissue. There's an infection known as CMV, or cytomegalovirus, and this causes calcifications in the brain as well. And this is usually the calcifications occur around your ventricles, so periventricular calcifications. That's something specific for CMV, where here it is intracranial calcifications, or inside your actual tissue of your brain. And that can be caused from chickenpox. So ELISA and PCR, obviously you're going to do to check for this guy, but just by clinical presentation, you should be able to diagnose this very, very easily. So variola, this is another infection. This is obviously something that's very severe. It's eradicated from the world. It's known as smallpox. It's a double-stranded DNA enveloped because it's a pox virus. Remember, our pox viruses replicate in the cytoplasm. This is a, it is DNA. So it is a DNA virus that invades the cell but doesn't go to the nucleus. It actually replicates in the cytoplasm. I just think of pox viruses as pretty much cells without ribosomes. They have everything. They have all the equipment they need other than ribosomes. So they can make their RNA. They can make everything they need. However, they can't make proteins. So what they need is just ribosomes. And guess where ribosomes are? They're in the cytoplasm. So why not just stay there once we infect them? And that is your smallpox. They have this like brick-like shape. They're kind of square, and those are your pox virus. It's also known as a complex shape. This is something that leads to simultaneous or synchronous eruption, which I was talking about before. It's a centripetal rash, so it goes to the trunk from your extremities, so from your face or from your wrists and hands, and it goes towards your trunk. And so when it's synchronous, that means they're all in the same stage. So all papules, all ulcers, as I mentioned before. That usually does start in the mouth and then progresses lower, but it can start in other areas. But the mouth is something they like you knowing for this guy. You're more likely not to get a question on this because you don't see it anymore. It's eradicated from the world, other than vials stored in CDC or Russia or something like that. I don't know. There's some conspiracy about that. Causes vomiting, diarrhea, and internal bleeding, which can lead to about a 30% mortality. So that's why this is bad. That's why we need to have this. Inhalation contact fomites is actually how you get it, upper respiratory tract. That causes viremia, which then spreads to the dermis, and that's where you get that rash. So vaccine for this is actually where vaccines came from, was from smallpox. So I'm sure you guys have heard about this story with the milkmaids that, they would milk all the cows and stuff like that. And there was this disease called cowpox, and there's another pox virus that would infect cows. And they actually would slightly infect, because it's a less virulent strain, infect the nursemaid. And so they have these little pustules around their hands, but they wouldn't actually have any disease. And so whenever they were involved and worked around with people that had smallpox, they would never get the infection. And so this guy called Jenner actually came together and was like, what if I take some of the scraping from this nursemaid's hands and then inject it into a small boy? Will I actually help him to become immune to this? And so he took some scrapings from the nursemaid's hand, which I'm sure wasn't enjoyable for her, and then take a little boy, grab him off the street. He's on his way home from school or something like that. His parents don't know, and he's just like, hey, can I inject you with something in your hand? And so he injected him with some of this cowpox. And then what he did was, he waited a little while, and then eventually kind of sprayed some smallpox on him too, to see if he got the disease, and he didn't. And so this is where we actually got the name vaccine, is because vaccinia was actually the cowpox virus, and vaca for cow, right? And this is actually where we get the name vaccine from. And so that's associated with smallpox. So now you know the story, and that should help you with the smallpox virus. So another pox virus is molluscum contagiosum. This is something that when you see the clinical presentation, you're done. Literally, if you see this clinical presentation, what the warts look like, you don't need anything else, and you just got a free point. So molluscum contagiosum virus is a pox virus. So again, cytoplasmic replication. That's important. It goes person to person, fomites, common with children, and then sexually as well. So it's usually localized in a certain area that gets infected. So children are obviously touching their face, so they touch fomites, they touch their face, and they're going to have it in their face. Person to person, that's kind of all over the place. And then sexual is obviously in regions of sexual areas, so genitals. Symptoms for this: it causes a benign tumor. It usually lasts about 4 years. This is self-limiting, so there's no real treatment for it. They're called water warts, so they're like the same color as skin, sometimes a little bit shiny. It has this pore, indent, or dimple that you find in the center of the papula, or the dome. And you can see these guys up here. You see the little dimple within it. And that is actually diagnostic for these. They have a pearly appearance, so they're kind of shiny. And so if we were to histo, if we chopped one of these guys up and cut it transversely across, it would be under the pore. We have this infected keratinocytes, and we call this a molluscum body. So this is something you want to look for diagnosis, or further confirmation, I guess. And if you have opportunistic infection, this actually can cause it all over the place, so this is bad. But again, remember, it lasts for 4 years. Children, it has this dome shape with a dimple in the middle, and that is your molluscum contagiosum. So some nodular lesions like Kaposi sarcoma, so we talked about this earlier, is HHV8. This is something you need to differentiate between your bacillary angiomatosis caused from Bartonella henselae, which is your cat scratch disease. So this occurs in HIV and AIDS patients. Is actually a tumor or a type of cancer that affects connective tissue, cartilage, bone, fat, blood vessels, and stuff like that. That's why it looks just disgusting. Can also have GI tract symptoms, because these can grow in the GI tract. So you need to do a punch biopsy and look for those lymphocytes trying to respond their best ability. Remember, your lymphocytes, your T helper cells aren't going to be really your prevalent things that are responding to this, because in AIDS patients, they're low. Remember this picture. This is actually pretty high yield. We actually had this exact picture on the test. But that's what that looks like. It kind of grows from our mucosal areas. And this is what it looks like on the skin. It's this dark, black, kind of gross looking thing. Looks like necrotic tissue on the skin all over the place. So human papillomavirus, this is it is the most common sexually transmitted disease. It's double-stranded DNA. It's naked. There's different serotypes for different disease, and this is actually super high yield for path and micro, so definitely make note of this if you don't know it already. So strains 1 through 4 causes the hands and foot, like the warts, just general warts, common warts. They often occur mainly in children, so just associate 1 through 4 feet and hand warts for children. If it's in the feet, it causes plantar warts or verruca plantaris. If it's in the hands, it's verruca vulgaris, because you make vulgar signs with your hands. And then strains 6 and 11, this is your Coniloma acuminata, or that should be an A, acuminata. And this is something that looks like warty lesions, usually in the anogenital area, but it is non-cancerous, and that is your strain 6 and 11. So be watching out for those guys. Other strains, and these are your highly infectious ones and more commonly tested, is your 16, 18, 31, and 33. This is anogenital infections. This is your one that leads to why we do pap smears and such, and so it can lead to cancers in those areas, also in males. Again, those common warts, genital warts, can lead to Coniloma acuminata. Pathogenesis pretty much is just growth in the stratum spinosum, and so that's why it's hard to get rid of it, because it's down deep into the epithelium. And it's the most common worldwide STD. Pretty much what you could do as far as some of the warts on the hands and feet, you can freeze, laser. Sometimes there's the vaccine for the 16, 18 strains. And diagnosis, pretty much you clean the wart with alcohol, you unroof it, and then you swab. This is actually super high yield. I don't know why it's so testable in micro, but I guess so because it's so common that you get warts. You want to make sure that your diagnosis is proper. So you got to clean it, then you unroof it, then you swab it in order to get actually some of these viruses, so you can diagnose it properly. So that's actually how you do this. So now on to our fungal infections. So our fungal infections are a little bit annoying with some of the names, but I have really good ways to remember, especially your dermatophytes, which kind of suck. But we'll be able to cover a lot of them over a short amount of period of time. So hopefully this is helpful. So for superficial epidermis and appendageal infections, we can start off with our white Piedra. We're going to get to black Piedra in a second. So white Piedra, I just think of, white sees the light on the outside, and so it's obviously you can see something that's bright and white outside. And so this is something that infects your hair follicles, and it affects the outside. So it just kind of grows on the outside of your hair follicle. It doesn't go into it. And so this is caused by trichosporin, and I want to emphasize sporin. White Piedra, sporin. We have another group of organisms called trichophyton. That is different. That causes skin and stuff infections. This is trichosporin. You see white things growing on the hair that can be pulled off and scraped off. That is white Piedra. This is trichosporin. So there are arthroconidia that can grow out on the surface of hair follicles. So they're easily pulled off of the hair, which if I ever got this or saw someone with it, I wouldn't say like, hey, how about you just pull at your hair for like 3 weeks? Just scrape all that off because it's just going to come back. So pretty much you tell them shave, give them some antifungal agents such as amphotericin B and ketoconazole, and that should be able to help rid this patient of this. Usually occurs in more tropical areas. It's a white or greenish yellow color, and you can see that down here in this picture. It's really gross. Black Piedra, on the other hand, it's pitch black inside here, and so when you're inside and it's dark, this is where you get your black Piedra. And so this is a fungus that actually grows inside. This is Piedra horte. It grows inside your hair follicle and can cause damage. And obviously, since it's inside, you can't scrape it off. So you cannot pull it off your hair shaft, and it's found inside. So pretty much what you got to do, you got to shave. Topical treatment with azoles sometimes work, sometimes don't. So tinea nigra. This is caused from Cladosporium wernicki. So this is superficial infection of your stratum corneum, and it usually occurs as brown-black lesions, mainly in your palms. So you have that really annoying person that sits next to you in class, or that one guy that always raises his hands to shout in class or something like that, to object to the IMCQ question or something. That guy, you really want to wring his necky with your hand. And then this is the thing that's causing this tinea nigra, which is Cladosporium wernicki. So when you're ringing that guy, and it occurs mainly in the palms, that's why I was mentioning that. But sometimes it's going to occur in the bottom of your feet. So pretty much how diagnosis is colonies of smooth with olive-like color that grow on our Sauerod's auger, which is what we grow fungi on, and they're halophilic. You can do salicylic acid as treatment. If you look on it on histo, it looks like sticks with clusters of little seeds, like seed-shaped spores. They're not round like when we get to Malassezia furfur, that looks like meatballs, spaghetti and meatballs. This is spaghetti and seeds. So see how they're like elongated seeds? They almost look like sunflower seeds or something like that. All right, so pityriasis or tinea versicolor. I know she might have mentioned the tinea, but I want you to know that pityriasis versicolor, anything with versicolor pretty much is what this means. This is caused from Malassezia furfur. This is super high yield to know this guy's name. This is pretty much almost guaranteed question on your test because it's actually a problem in not only just dermatology, but I'll be mentioning that in a second. So this is a dimorphic yeast. It's lipophilic, so therefore it grows on olive oil, and this is really cool. I'll be mentioning that in a second. So endogenous skin flora, it eats like the sebum-rich area from sebum-rich areas like chest, back, abdomen, neck, stuff like that. And it's usually occurring in areas where it's very humid and elevated temperature. Such as the tropics and areas where we live right now, down in Grenada. So symptoms, you get superficial macular rash, and you have scaling of the areas that you have this infecting. So it appears darker or lighter than the surrounding tissue. So here's dark skin, and then here's the tissue that's infected from this. And it can change color on contact. So if I were to wipe my hand on this guy's back, it actually wouldn't be just white. It would go to a gray color. It's kind of interesting. It's almost like those pillows that have it's like furry pillows. When you slide your hands one way, it's like dark blue, and then you slide it the other way, it's more like a light blue because the hair stands up in a different direction. So that's actually how these guys, how this kind of works when you touch the skin. It's kind of interesting. So microscopy is going to be your spaghetti and meatball appearance, and so your spaghetti and meatball grows with olive oil. So spaghetti and meatball and olive oil go together. And so this is actually something else you can do is under Wood's lamp, which is like a UV light. You can actually fluoresce it and it becomes golden yellow on Wood's lamp. That's very, very high yield. Treatment for this, selenium sulfide shampoo, which is pretty much Selsun Blue, which I have depicted down here. Sorry if you're not from the United States, but we have Selsun Blue in the United States. So that's my reference for selenium sulfide. You might have other shampoos. Antifungal sometimes work, but not always. This is actually often mistaken for vitiligo because patients like to rely on WebMD for their conditions. So they say, my skin is changing, and then the first thing that comes up is vitiligo. And this is very problematic because it's often seen in psych wards or patients that come in the emergency department that try to kill themselves. Teens or especially teen girls that have this very superficial thing, or they're kind of wanting to impress people when they start seeing their skin changing, such as in their abdomen or their chest or their arms or something like that, or their shoulders. They think that they need to look it up, and vitiligo comes up, and they're very scared. They think that this is going to be deforming. And this is actually a lot of cases coming to the emergency department of children trying to commit suicide based on this presence. But simply, all you need to do is give them selenium sulfide because they most likely actually have this fungal infection called tinea versicolor or pityriasis versicolor. And so this is something very simple. Vitiligo is actually not very common. And so to have someone or have this coming up so common, we need to be looking out for this infection. And here's your spaghetti and around the meatballs. Spaghetti and around the meatballs, where the other one back here was more of seeds for tinea nigra. All right, so dermatophytes. So now onto our dermatophytes. These are actually my favorite. I hated them at first, but they're actually not that bad. So this is your trichophyton, microsporum, and epidermophyton. And so these are fungi that infect and eat away your keratin pretty much. That's a nutrient source. Invasion of skin and hair and nails, and they have a different arrangement of which ones they do infect. So the risk factors are old age, diabetes, collagen vascular diseases. You can get it from different areas, just from contact, like dirty shower mats. So if you're living in a dorm on campus, make sure you're wearing your flip-flop, shower flip-flops or something like that. I know being a real man and not wearing shower slippers or something like that, yeah, but well, you don't want dermatophytes. So other like nail hair clippers can lead to infections of the nail, and combs as well. It's annular scaly patch, raised margin. This is also known as ringworm, if you ever heard that, or jock itch if it's in that particular area. It can cause hair loss in this area, and it's this dry, crusty-like thing, so it causes this ring. So it's very common. This is what causes athlete's foot in the foot. So onto organisms. So trichophyton. So this is something that does not light up on Wood's lamp. So there's no color for any of the organisms within trichophyton. So the three that are found within here are trichophyton rubrum, which is actually your most common. So I'm going to circle this as actually your most common that you're going to find infecting anyone with dermatophyte infections. So it's white fluffy on top that grows on auger, and then on the backside is actually red. So here's the top. So, hey, look, I'm growing fungus on my auger, and it's white. And then I flip it over, and it's red. Guess what I have? I have trichophyton rubrum, which is why we call it rubrum, because it's red on the bottom. This is your when in doubt organism. If you have something with like a ringworm infection, you think it's a dermatophyte thing. If it's not any specific particular one that I'm going to be emphasizing later, then just go with trichophyton or trichophyton rubrum, because that's the most common. Other guys, mentagrophytes and tonsurans, those are other guys within your trichophyton. So pretty much what these guys, because they're the trick of all trades, they infect all. That's the trick. They infect skin, hair, and nails. And anything with phyton in the name actually infects nails. So, because you know why? Because you fight with your nails. Okay, so morphology for this is microconidia, which is your birds on a wire appearance, which is this guy up in this picture. So you can see your wire, and then you see your little birds. If you do a scanning electron micrograph, which is down here in this picture in the right, is actually what this looks like. So now you know why there's birds on this wire. That's actually what our trichophyton looks like. On macroconidia, it's this pencil-shaped thing up here in the top right, because it comes to a point here, so it looks like a pencil. I really think it looks more like a ladder, because it's got these little prongs, right? Like it's like a long ladder. I don't know, whatever you want to use to describe that. It's very long, it's straight, and then it has this point at the end, and then it looks like a ladder. That's what my trichophyton will look like on macroconidia. Virulence for this, it has keratinases, so that's why it can infect and eat hair and skin. And then mannan lipophilic toxin. This is something that could lead to cell-mediated immunity and keratocyte proliferation being inhibited. Tinea corporis is a very common thing that these guys do, ringworm of the upper parts of the body. And yeah. So epidermophyton, so this is really nice. It actually tells you the two things that it infects. It infects the skin, or epidermis, and it infects your nails. Remember, you fight with your nails. But it does not infect hair. So these last two groups, epidermophyton and microsporum, actually only infect two things. And so we want to emphasize those two things. Where trichophyton was the trick of all trades, so it does all three, where these only do two. So here it's epidermis and fighting with your nails. So morphology pretty much is your macroconidia, because there's no microconidia. And they're small walled banana-like clusters. We also call it our beaver tail, which I think it really looks like a beaver tail as opposed to anything else. And that is your epidermophyton. And this is caused from epidermophyton floccusum. So microsporum is our last kind of group of our dermatophytes. And so this is something that attacks your skin and your hair. Do you see phyton in there? So it doesn't do nails, so it does the other two, skin and hair, which is nice. This is more commonly associated with Microsporum canis. So this is something that fluoresces, it has urea, and it has hair perforation. And this is what this guy looks like. They're kind of these like weird, pointed, almost like bowling pin-like shape. But they have rough walls on them. They're kind of sharp, jagged things. Gypsium and Aduani. So gypsium actually is for hair perforation, because I just remember gypsies have really messed up hair. They're kind of scraggly and stuff. They haven't washed their hair in a while, and that's your hair perforation. And then Aduani has fluorescence, and I have no way to remember that, but just remember that's the other guy. And remember, our microconidia you usually don't see them. It's something we don't see very commonly. It's usually macroconidia that we see very commonly. That's why we have pictures of them. So tinea capitis, so let's talk about the diseases that these dermatophytes actually cause and where they're located. This one is actually more detailed than the rest, so don't get too scared about what's about to come. So pretty much tinea capitis means on the capit, which is on your scalp and your eyebrows and your lashes. And there's two kind of organisms that or two classes of organisms that cause this infection depending on where you're going to find it. So ectothrix, which is pretty much a fungus that forms a sheath or hyphae around the shaft of hair, and it becomes brittle and stuff. It's very similar to our white piedra that can cause from Microsporum adoani, canis, or gypsum, where your endothrix, which is hyphae invading the hair follicle to form spores in the hair follicle, that's going to be kind of the endothrix, which is Trichophyton tonsurans. So this is actually low yield because it's kind of hard to differentiate between your piedra, but be careful with that and look out for them. The one differentiating feature for the endothrix from your black piedra, once it's inside, it actually forms this black dot appearance. When you see black dot appearance, you're thinking of Trichophyton tonsurans as opposed to your black piedra. So that's a nice thing differentiating between these. So tinea barbae is the infection of the beard. Pretty much you need to just know that it's called tinea barbae, and you recognize that it's ringworm of the face of where your beard is, and that is tinea barbae. The organisms, aren't that high yield, so don't worry about that. It can cause pustules and stuff. Pretty much don't shave because that can make it worse and spread it. Tinea corporis, this is of your upper body. Ringworm most commonly is going to be your Trichophyton rubrum, trunk, shoulders, axilla, and stuff like that. Tinea cruris, this is something that affects the inguinal region, also known as jock itch. And so it's in your perianal or perineal areas, because it's sweaty down there, you can lead to this jock itch. This is most commonly caused from your Trichophyton rubrum. This is actually the most common cause. So if you're when in doubt picking that guy, then do it. However, if they want to do a little bit more specific and want you to pick epidermophyton, you're going to need to be looking for those the specifics for the epidermophyton that's different than Trichophyton. It's usually scaly, inflamed borders and stuff like that. It's itchy, burny, and dry in those areas. And I like this little comic down here. I wish I could scratch my ears. And this guy's okay. So tinea pedis, this is your pretty much athlete's foot, and it's chronic infection. Most commonly, again, Trichophyton rubrum. It is the most common. So you got flaky and grossness on your feet. Smells really bad, scaling, fissuring, erythema. It's very itchy. It's also called moccasin feet. Then you need to get some fast-actin tenactin. Spray that on that. That is tinea pedis, caused from Trichophyton rubrum. So tinea unguinum. So this is actually infection of the nail plate, and most commonly is Trichophyton rubrum as well. And any of our trichophytons, because they infect our nails, or any of our phytons pretty much. It's what you want to be looking out for the answers. But pretty much this is another thing that they like to ask, do you just know the name of what it's called to infect the nail? And that's tinea unguinum. All right, now on to the dermis. So this is more dangerous infections of the skin. So this is chromatoblastomycosis or chromomycosis. And this is chronic subcutaneous mycosis. It's caused from these pigmented hyphae, chromatomycosis or chromatomycoi. It's traumatic inoculation of skin, and that leads to this infection, and it kind of migrates up and stays in a big patchy area, which is kind of gross. It's painless wart-like lesions. They're granulomas that form, usually on the feet or legs. It's very common on the feet or legs. If you see this gross thing happening on the feet or legs, then just pick chromatomycosis as opposed to sporothrix, which we'll get to. It causes abscesses sometimes in the upper limbs, or up the limb, following the lymphatics. So that's what it looks like. It's this red, gross, granulomatous, patchy thing that migrates up with some abscess in it, and that's your chromatoblastomycosis. So Eumycetoma. This is a bonus guy. They did not teach this in skin, but you do need to know it for step, so I want to emphasize it here so you can actually recognize it. So this is called Madura's foot. This is Actinomadura maduriae. There's also a couple other things that cause this, like Pseudo-Alesiaceae boideae. I don't know how to fully pronounce that, but Actinomadura maduriae is gram-positive. It's one of your actinomyces groups. So similar to actinomyces we talked about infecting the face, this one, if it infects the feet, specifically this maduriae, then it can lead to Madura's foot, which is also called eumycetoma. Pretty much you get it from polluted water and walking around barefoot. Usually infects immunocompromised patients. And so you got to be careful with those. So you have a local swelling with pruritus and suppurative, and it forms abscesses and very granulomatous, and it's really, really disgusting. So I just want you guys to be able to recognize that as it comes up again in term 5 when you have your infectious disease. It's not super common, but actinomaduriae causes Madura's foot, which is granulomas of the feet. So be looking for that guy. All right, sporotrichosis, which is rose gardener's disease. It's a fungus that's found in soil, plants such as rose bushes, because it's rose gardener. And you can get it in moss, also from cats and horses, but really be thinking about it from plants. So people that work in their rose garden, they sometimes get a prick on the hand and or on their leg or foot or something like that, and it leads to this disease, which this is caused from Sporothrix shankii. So when you get shanked by your roses, you can get this, which is amazing. I love this name. When you get shanked from it, then you can get this shankii or Sporothrix shankii diseases, and it's associated with getting shanked from your rose bush spines, which is nice. It's a dimorphic fungi. This is super high yield. That's why I have it in bold, to know that this is dimorphic. Know your dimorphic organisms, and what this means is that they have two different stages. They have a yeast and they have a mold stage, and these actually grow at different temperatures. So for Sporothrix shankii, when it's in the yeast stage, it forms these cigar-shaped yeast on microscopy. So they look like cigars. This grows at 37 degrees Celsius. This is so high yield. Like, if I were to ask you a hard question about this, a third order, you're asking about this particular stuff right here. If it grows on agar at 25 degrees C, then it's going to be in its mold form, and it forms these like flower-shaped things on the agar. You can Google that and look at the pictures of what that looks like. They look like flowers on agar, or microscopy, they look like cigars in the yeast form. Transmission pretty much from the thorns and splinters. You got to get cuts in the skin. It's painful nodular swelling that migrates up the lymphatics and in a linear fashion. So you can see this kind of organizing up here, moves up, infects, causes an ulcer, moves up, infects, causes an ulcer, and continues up like that. And then pretty much what you do is you give potassium iodide. You can give that in milk, and that is a treatment for this.
All right, and now onto our protozoal and helminth infections of the skin. So the first that we're going to get to is known as leishmaniasis. The organism that caused this has multiple different species, which is Leishmania tropica, Mexicana, Brasiliensis, and Donovani, which is the one that causes the internal or visceral Kala-Azar. So the transmission from this, I have a kind of a cool way of remembering this. This is your phlebotomist, Lutzomia sandflies. So if you could just remember the sandflies that they cause leishmania, that's the easiest way. So here's a little sandfly. We call it the sandfly because it has a sandy color. But I just think of it as you're in this giant desert out in the sand. And you look around and you see these giant flies walking around all over the place. And you're like, what the heck? This is weird. And they all have on leashes. It's like a leishmania. Oh, leishmania. And so these flies are on leashes. And so that's why they're sand flies in the desert on leashes. And that's a leishmania. So the disease that it causes is the cutaneous form. And this is actually the most common form of this. And it pretty much just causes skin sores. It can be found all over the body, very commonly in the face. Visceral leishmaniasis, which is called Kala-Azar. This is infection of the spleen, liver, and bone marrow. This is very severe, so we definitely need to be treating these patients with antiprotozoals. So diagnosis is going to be finding mastigotes inside macrophages or the trophozoite form. So here's a macrophage up here with our trophozoites. It looks like almost like there's little egg-shaped beads or marbles or something inside of these macrophages. Just try to be able to differentiate between histoplasmosis in macrophages and these guys, and that's going to give you a way at what your infection is going to be caused from. And then we have our trophozoites, which are these guys down here. They pretty much look like avocados with points at the end. See, they have their little avocado pit in the middle, the avocado-like shape, and then they have a little tail. So drew a little tail down here on the avocado, and that is your leishmania. The next guy is loiasis. As the organism is that causes this is loa loa. Pretty much loa loa means wormy worm. This is a filarial roundworm found commonly in Africa. And the transmission from this is your chrysops fly, or your mango or deer or yellow fly. And so it's the chrysops is the actual genus for this. And so the way I kind of remember this is that it's on the island of Loa Loa. There's this cyclops that lives there, and I put this picture down here. This is from the Odyssey, because there was that cyclops on that one island, and so that island actually was called Loa Loa, or at least I'm telling you right now, in order to remember loiasis, that this is the island of Loa Loa, and the cyclops that lives there, what he does is he eats mangoes, so that's your mango fly, and he only has one eye, so it infects your eye. So this is known as your eye worm. If you haven't heard of this before. So this is an infective stage for this will be your L3 larva, and microfilaria is the diagnostic stage, and that's pretty much what we can find in this guy's eye up here. So the disease progresses kind of from where it infects, and so you have these red itchy swellings that under the skin, and they migrate along the skin with the worm, and they're called calabar lesions or calabar swellings. This is actually super high yield. If you see that in a stem, we pretty much are talking about Loa Loa. So the way I kind of remember this is in that movie with, or about the mummy. It's actually the first mummy movie. And what happens is there's these little scarab beetles that run around, and if they bite into you, they kind of crawl into your skin in this giant lump that moves. And this is a problem because this is actually very similar in presentation to these calabar lesions. So wherever the worm is moving, you'll have this giant swelling that moves with it, and that's known as a calabar lesion. And then they can eventually make their way up to under the eye and the face, and then into the eye themselves, as you can see this guy up here. If the worm dies, however, you can lead to like a granulomatous and fibrosis in that general area, and often because it's found in Africa, it's actually often associated with other fly infections, which gives you a disease such as onchocerca, which we're going to discuss in just a second. So diagnosis is the eosinophilia and microfilaria on that microscope, and that is Loa Loa. Next is onchocerciasis. The organism is Onchocerca volvulus. We call this disease that it causes is river blindness. It's transmitted from the black fly, which is this really cute little fly up here with the little white spots on its bone. The disease that progresses, and different portions of this disease, is you can have subcutaneous migration. And so it's kind of similar to our subcutaneous migration of the worm, but it doesn't cause calabar lesions like we saw in Loa Loa. You can have very small nodules that you find in maculopapular rash with pruritus, and once that area has been infected from that worm and it migrates somewhere else, that skin can have hyperpigmentation and skin wrinkling. The skin wrinkling is pretty much because this worm eats elastin fibers, and so when you destroy the elastin fibers, you're not going to have elastic skin, and so it gets all wrinkly and old. Other things, and this is the most common thing that you actually see this with, is African river blindness. It makes its way up to the eye, and it actually eats all the eye tissue, the retina, and everything. And so this is the second most common cause of infectious sight impairment, following chlamydia trachoma or trachomatis. The worm itself has actually a symbiosis with a bacteria known as Wolbachia. This is something you find also in lymphatic filariasis, which is Werkeria bancrofti. I'm sure you've heard about that after your malaria lecture. And so what we do to target this worm is actually targeting this Wolbachia. So this Wolbachia, actually what it does is it provides nutrients and allows this worm to actually sexually reproduce. However, what happens is the worm actually is unable to reproduce once we kill this bacteria, and we use doxycycline to do that. This is something you should definitely be able to recognize up through term 5 and everything. You're going to learn about this drug, but I'm teaching it now so you'll know. The way I can identify the worm, it looks like a leopard kind of worm. It's got all these little spots all over it and stuff like that. And that's how I can spot Onchocerca. And definitely Google a couple other pictures to know what it looks like. So the next worm is Mantellinelosis. This is caused from Manzanella streptocerca. The vector is Colocoides midges. So if you just remember midges, this carries Manzanella. This is known as your walking stick or cane-like worm. That's the common name that we give it. So it looks almost like a walking stick. You can see here, duh. And that's why I put in a little candy cane. We're getting close to Christmas. And so just hopefully that brightens your spirits that we're almost there, almost to the end of the term. So it causes chronic papular lesions, not popular lesions, with hyperpigmentation. L3 larva is infected in microfilariae. So pretty much because this is so similar to Onchocerca as far as the presentation, you pretty much have to say it's not infecting the eyes, it's carried by midges, it's called Manzanella streptocerca, and it looks like this guy on histology. So next is cutaneous larva migrans. This is actually very common. You're probably going to come across this in practice. And this can be caused from a lot of different worms. So Ankylostoma braziliensis, A. caninum, Necator americanus, which is that hookworm we covered before in GI, Unicaria stenocephala. All these guys can cause this cutaneous larva migrans. Pretty much what it means is under the skin, there's worms crawling around. So if you've heard about ants under the skin as far as alcohol withdrawal, well, just imagine worms under the skin, and that's this guy. So it causes a creeping eruption that just moves around. You can see it on this guy's foot down on the bottom right. And this is after falling of penetration of, and this is the most important part, this is what they're going to test you on, the Fulariform larva. So this is a little guy that actually infects this. Usually you find it in like shady sand or dirt area on the beach or in the dirt or the grass or something like that, especially on the grass for hookworms like Necator americanus. And usually we find this guy in the southeast United States. It's very common to find that there. So it causes this serpinguinous or snake-like under the skin, and you can see the little tracks that this guy is following around in here. So pretty much diagnostic, you just need the skin lesion. You can see it, great, I know what you have. Sometimes we give topical anti-helminth, but usually they're self-limiting in about 4 to 6 weeks. So enjoy that wonderful feeling for about 4 to 6 weeks. I can't imagine that. So next is trichinosis. I know there's a lot of tricks and everything, but hopefully if you can just hook up trichinosis with Trichinella spiralis, I think you shouldn't mess this up with any of our other tricks. So Trichinella spiralis, I just remember the spiralis parts, or T spiralis, actually because it forms spirals. So you can see this organism up here, it actually organizes itself just like this, so it forms a spiral. That's why we called it that. So this is usually we get this infection from ingestion of infected bear meat or pork or other sort of meat. So what happens is this organism actually makes its way, it's an intestinal infection. You know, we eat the meat, or other organisms eat the meat. So a bear eats something else that has meat or something. And then it's an intestinal infection, you know, GI, abdominal pain, diarrhea, vomiting, stuff like that. But then the organism makes its way to encyst in the muscle. And this is what it looks like. You should definitely be able to recognize it on histology and in gross image. So here is what it looks like. You see these little bubbles. And these are calcified incestation of trichinosis. On histology, we see our muscle fibers here, and we also see our muscle fibers here as well organized, and we can see when we do cross-section, we have this little spirally kind of thing. This one's not super spirally looking, but definitely be able to recognize that it is located in muscle. That is muscle. I see something in the muscle, looks like cysts in the muscle. Then we're talking about Trichinella spiralis. The other symptoms that present with this disease, and this is something actually like kind of cool to be able to spot in someone and think to ask them, hey, have you eaten any bear meat or pork meat that you didn't cook very well or didn't leave in the freezer for about 6 weeks? So this is something that presents with periorbital or facial edema. This is something usually we wouldn't see as far as an infection goes, but more something having to do with renal disease.
But this is something having to do with infection. So you'll see a fever, periorbital facial conjunctivitis, myalgias, splinter hemorrhages in the fingernails. Sometimes you can see a rash, and eosinophilia kind of gives it away. Hey, we have a worm that is causing periorbital facial edema. I'm thinking maybe this person has been eating meat. So that kind of gives it away with that. So pretty much the history of the contaminated meat is going to give it away as well. Diagnosis is ELISA, or finding the encysted larva in the meat that the person ate. Or we can do a muscle biopsy to find them in there. But obviously it's, I could punch out this area and not get one of these. I would actually have to do multiple biopsies to see if I can find it. And the last infection that I want to talk about is osteomyelitis. And so this is an infection of the deep bone, something that's more like bone-eating disease. The most common thing is Staph aureus. This is usually hematogenously spread. Like I said before, if you have staph infection, you have to assume it's MRSA, so definitely giving antibiotics to cover for MRSA. If there's extensive damage, then you pretty much have to do surgery to remove the general area, which I'll be describing in just a second. Other organisms that can cause osteomyelitis, it kind of depends on the exposure. So if this person has a surgery, like putting in a prosthetic knee or something like that, and then they have osteomyelitis and deep knee damage, then you're thinking that more it came along with the surgical prosthesis, and that's going to be your Staphylococcus epidermidis. That's the most common associated with that. Puncture wounds, you can think of Staph aureus as well, but also Pseudomonas, especially if it's on the foot. This is something that's very common you want to look out for. Now, this is very high yield as to why I have it all in bold. If you see someone with osteomyelitis and they have sickle cells, so it describes, they had sickling cells, or they had many episodes of knee pain and something that had to be treated with, morphine severe. They had dactylitis, and they had a bleeding disorder or something like that, and it's maybe an African American female or male or something like that. Then at that point, you want to be thinking, what could cause osteomyelitis in this person? And I wouldn't choose staph, and I wouldn't choose any organism than salmonella. Why? Because with sickle cell patients, we actually have autosplenectomy. And autosplenectomy gives you increased risk of having infections from organisms that have capsules. Right? Our spleen actually filters the blood of capsular organisms like strep pneumo and stuff like that. So strep pneumo, with sickle cell patients, you can have increase in pneumonia and such like that, or meningitis. However, if we're talking about deep bone infections, strep pneumo doesn't cause that. Salmonella, on the other hand, does. So you want to be looking out for that guy. If you have a cat bite, which comes back pretty much to our first organism, which we talked about, you want to bring back that Pasteurella multicida. So again, the most common cause is hematogenously. It's usually monobacterial, and you can see the location for this in children. That's like periosteal abscesses, usually in the metaphysis. Why? Is because they have a lot of blood supply in that area. Why? What's in the metaphysis? Well, in children, we have growth plates, and growth plates need a lot of blood in order to grow. So that's why this blood, or this area, actually has an increased risk of having osteomyelitis if bacteria gets in the blood. In adults, it's usually to the vertebrae, so they'll have lower back pain or something like that. They're warm, they have a fever, recent some sort of infection or something like that, then be looking for osteomyelitis of the vertebrae. So pretty much treatment for this is weeks and weeks and weeks of bactericidal agent, IV at first until we can get a handle of this, and then we try to switch them over to oral so we can send them home. So the hospital bill doesn't get crazy. So I want to show you guys these pictures of osteomyelitis. So this is actually pictures that I took in India over the summer. And we actually had this patient with diabetic foot, ended up getting an infection that caused osteomyelitis. And you can see, we are missing a few toes and half of toes here. And so this bacteria actually ate away at all the bone here. And so we had to do surgical debridement, pretty much chop off 3/4 of his foot. And this is actually my friend Tanisha. She's the one that actually assisted in this surgical debridement of this area. And then they had to do vascular surgery to fix all the blood because it was bleeding a lot. So this is a very severe thing, and if we don't get a handle of it and get antibiotics into them and be able to control it, if it's out of control, we need to start surgically removing some certain things. And that pretty much ends the video. I hope you like this, and I hope this helps. Subscribe to the videos, and there will be more for each of your modules. All right, happy studying, everybody.